Hey everyone, good morning. I don't know if you can hear me. Hey, Kadeen. A few more people are still taking the quiz down to the last minute. The sun, bright and shiny today. That's good. Well, the quiz wasn't too bad. Was this subjective? We'll get started here in about 2 minutes or so. If you have any questions, feel free to post them up. I'll take a look at the quiz after class today and see if there's any high misses or anything, and kind of go from there. Morning, Nisha. Mina. 21 in here is pretty good. Yeah, looks like everyone's done with the quiz, so it's good. Alrighty. So, let us go ahead and get started here. I'm gonna get your prescription assignment done this weekend, or I'll have it done by this weekend, and then I'll get the next one posted up. You don't have it due until I think like the 19th or something, but you have a while, so 1, 2, 3, about 3 weeks, so it should be more than enough time. So I'll get that posted up for you guys and be able to do that with some feedback from the first one, so that's good. All right. So we were discussing our antipsychotic drugs. Did have some review of that from the quiz now. We talked about some of the challenges with them, especially with like their acute use and also the chronic use of them. And now we can start to talk about the second gen drugs, which sort of get around a lot of those issues there because their mechanism is different. And we also call these atypical antipsychotics. The nice thing here is they don't focus so much on the dopamine blockade. They still do that to some degree, but it's not nearly as strongly as you would see with the first gen drugs. So they have a lot fewer extrapyramidal side effects and the prolactin issues. So we really don't see a lot of issues in terms of like acute dystonias due to these drugs here. And because they're working more on the frontal side of things, as we'll see here in just a second, they're a lot better for negative and cognitive symptoms. So it'll still deal with some of the positive ones. It may not be as good as the first gen drugs for the positive symptoms, but they can certainly still help out with negative and cognitive ones. There's also a lot less tardive dyskinesia, so that's really the good thing, is because this is a lifelong disease for many people, and so having something they can take for that lifetime is good without causing, really kind of deleterious effects that may not be reversible in a lot of cases there. So in general, these should be the first line drugs that you're going to be going with here. The reason why they get around some of the issues that the first gen drugs do is because while they do have some ability to affect the D2 receptors and that striatal tract, it's lesser so than the first gen drugs. The primary thing they're doing here is antagonizing these serotonin 2 receptors that are in this sort of mesocortical pathway. So up in the frontal pathway where a lot of those, negative and cognitive symptoms sort of arise, that's where that's being affected there. So how this would look if you were to kind of envision what the sort of complex sort of interplay is here between these neurons. Excuse me. Whereas the positive symptoms really come from this nucleus accumbens here, and this is where most of your first generation drugs really work here. Instead, what we're seeing is that the second gen drugs are helping to block this serotonin receptor here, and this allows for sort of more normal functioning between these neurons. And I'm not going to get real in the weeds in terms of like, the effects of stimulatory versus inhibitory neurons on other neurons, but just suffice it to say that by focusing on the serotonin receptor, you're able to deal with the negative and cognitive symptoms as well as deal with the positive symptoms as well due to this sort of interplay here between inhibitory neurons. So that's why we like them. You'll see in terms of adverse effects, there are going to be some metabolic issues which patients may have to deal with over the long term. And so we'll see sort of which ones are going to be better for these metabolic effects than others, and we'll kind of see which ones you probably want to go with, kind of first line versus some of the other ones. But weight gain can be a big issue with these drugs, especially olanzapine and clozapine particularly. It's not uncommon for a patient who gets put on olanzapine to put on like, 30, 40 pounds, just due to the effect of the drugs itself. You'll find this is a lot less with something like ziprasidone or aripiprazole. I'll give you the list of the drugs here in just a little bit. And typically, if you put a patient on one of these meds and you see that there's over a 5% weight gain, then you typically want to switch them over to something else if possible. Some patients may kind of fail everything else and require something like olanzapine, and then you just have to kind of work around that in some cases. To go along with that increase in weight, you also have things like new onset diabetes. Clozapine is particularly bad about doing this. You'll see some lipid changes as well. One really notable side effect of clozapine is this agranulocytosis. It actually has a REMS program pretty similar to stuff like Accutane, where the patient has to come in and get monitored for their CBCs in order to even get their refills done. And because it could happen in 1 in 100 patients, and that could be quite fatal if you run out of your granulocytes, obviously, because you'd be at big risk for infection. So that's something where we try to really hold off on clozapine unless absolutely necessary. So not common, you'll see patients on it, but every once in a while. And then certainly you can see QT prolongation, so you'd want to monitor for that. Checking EKG, especially if they're on multiple meds. If they're on something like citalopram plus, antipsychotic or atypical, that could be problematic if you're not watching it. You also see some blood pressure issues, particularly like in elderly patients, or if they're getting like big IM or IV doses, which you might see like acute sort of psychotic episodes. This should be dealt with over the course of 2 or 3 months or so. A patient should get pretty tolerant to it. But early on, that could be something you may want to watch out for, especially if they're going from sitting to standing and they get dizzy and they're likely to fall because of maybe other medications that they're on that are making them dizzy. That could be problematic. One of the other things you'll see here with the atypical drugs is that they are fairly sedating. They are good for dealing with patients who are having acute bouts of aggression or anxiety. However, people have tried using these for elderly patients, especially if they have like elderly related psychosis related to their dementia. And you can see this a lot like in healthcare settings where patients will have what they call sundowning, where it becomes nighttime and they're in an unfamiliar environment and they get very sort of agitated and whatnot. They actually do find increased mortality if we're using atypical drugs in these patients here, so they try to avoid those if possible. Along with that, you'll see a lot of sedation with these drugs here, particularly clozapine, olanzapine, and quetiapine are particularly notable for that. So if you can dose them at nighttime when they're going to be sleeping anyway, that can be useful. And then some of these will have anticholinergic effects. So, the whole mnemonic we talked about, blind as a bat, mad as a hatter, all of that. Clozapine and olanzapine tend to be particularly bad. So you can kind of see a trend here, like clozapine and olanzapine are probably the ones you want to stay away from unless absolutely necessary. And especially if they have a seizure history, this would be ones you'd want to avoid as well. Again, these are going to be for patients who have failed multiple other trials of other drugs. And this is like the only thing they have really left to try, fortunately. Generally speaking, the biggest drug interactions you're going to run into are going to be more from a pharmacodynamic sort of nature, meaning if they're on other drugs that are sedating, this will cause them to be more sedated if they're taking these as well. If they're on multiple anticholinergic drugs, then yeah, they're going to see enhanced effects there. If you're putting them with other dopamine blockers, so something like metoclopramide or promethazine, then yeah, your risk for EPS does go up. It's generally pretty low by itself, but when you start to combine multiple dopamine blockers, yeah, that's when you run into some issues there. So here's a list of the drugs that you can run into. So you have things like aripiprazole, clozapine, iloperidone, ziprasidone, paliperidone, olanzapine, quetiapine, risperidone, acinapine, and then lurasidone. Again, I don't really care necessarily that how many asterisks are on each of these boxes here. But again, knowing the kind of general trends, and you can focus on the other slides that preceded this one to get a good idea about what kind of things I'm going to be focusing on from a from a testing perspective here. Generally speaking, though, like olanzapine and clozapine, you probably want to stay away from. Things like risperidone and aripiprazole tend to be pretty well tolerated. That's probably going to be the first med that most people probably get put on. You're starting to see like aripiprazole being used for more like treatment-resistant depression and things like that too. Here's a good slide kind of comparing your side effect profiles between the typicals and atypicals. So you can use this as a guide to sort of help you in your studying to get a feel for sort of the differences and flavors of side effects that you'll see with these particular drugs here. So I'm not going to rattle on about these specifically, but again, good for your review. So in terms of monitoring, basically the biggest thing you want to look for are going to be their weight, blood pressure, all the metabolic stuff that we talked about earlier, and then any antipsychotic side effects like the EPS. If you can try to sort of catch that early, you may be able to switch them to something else, or maybe decrease their dose, something like that, to try to help and curtail that if you can. So with acute treatment, sometimes these patients may be presenting, like for instance, to the ER either for the first time or perhaps having an acute episode where they can become quite aggressive, quite dangerous to themselves or others, especially if they're having, active hallucinations that are telling them to harm somebody or something like that. And so these can be, dangerous patients to deal with. And so fortunately, a lot of these meds like haloperidol and ziprasidone and things like that can be good if used like from an IM setting to sort of calm these patients down as a means of chemical restraint. Not always the greatest thing to do to a patient, but if it's one of those kind of harm to other people situations, then you may need that. Benzos can also be used as well, so you may have these patients having an acute psychotic episode that may require things like benzos, like lorazepam for instance, plus something like haloperidol. That's a pretty common combination you might see there. And again, think about the route you're giving these medications. A lot of these patients are so aggressive that getting an IV would be quite dangerous. So IM administration is important to be able to consider there as well. You can do that a lot easier by being held down than getting an IV started, which requires some time and skill in order to get there. It's pretty easy to give an IM shot. Basically, though, if they're more in a calm state, then again you can start normal doses of medications orally, and then basically give it about 3 to 4 weeks, see how they respond, and then you can try switching to a different agent if need be. So if they don't really respond well to risperidone first, and you can try aripiprazole, or you can try quetiapine, something like that. For patients that do have compliance issues, which this can be a challenge for this patient subset, especially if they're having, impulses that they don't need to take medications because they're fine, then we can use long-acting injectable forms. And so you can have things like depot shots of things like olanzapine, haloperidol, things like that. Keep in mind, you want to do this for patients who you already know are going to respond well to the drug. Because once you give this, you can't really take it back. So you wouldn't want to do this with a brand new drug that a patient's never experienced, because they could be having these side effects for like months. So you would not want to do that. Basically, if you needed to discontinue, I probably wouldn't do like an abrupt discontinuation because you could have kind of recurrence of, their psychotic symptoms, and so you generally will taper off. And then if you're switching agents, then basically you want to try to taper off one while you're sort of increasing the dose of the other, so that way you're not giving them like a full like washout period, like you might see for other drugs. But it will provide them coverage so that way they're not going without any medication at all, but it allows for a little bit more of a graceful transition as you switch them from one drug to another. That's it for this section for the antipsychotics. Of course, if you have questions, feel free to post them up on sticky board or in the chat. I'm going to keep going though. Next, let's talk about anxiolytics. I'm sure you guys had some anxiolysis as soon as the test or the quiz was over there. And when talking about anxiety, this kind of refers to it's kind of a broad umbrella that encompasses a lot of things, from generalized anxiety disorder to specific phobias, obsessive compulsive disorder, things like that, all fit within under this category here. I always love like really specific phobias. Their names are always like really interesting to me. So one of my favorite ones is thalassophobia, which is fear of like deep water and the things that may reside there. So kind of fun to think about, but sea monsters and whatnot. But anyway, so stress and anxiety is typically like a healthy response in a lot of cases, because that's kind of gives you your survival instincts from way back in the day when it was us versus nature, basically. But you will find that there can be sort of a maladaptive response if not managed effectively. And you'll see that this can arise from a lot of different things, but mainly we're going to see that our main neurotransmitters at play here are going to be norepinephrine, serotonin, and then GABA will also be useful here. And of course, there's lots of things that can cause anxiety, not just, normal reasons for stress, like you have a test coming up, but it can be other things like medications. And so I always like to focus on these things because it's important to consider what meds might be causing anxiety for your patients, because if you can get rid of them or switch them to something else, that's obviously better than trying to add on another medication. So fewer drugs are better, as it turns out. At least that's my opinion. But things like, hallucinogens. So if someone has, took some LSD and all of a sudden they're having a bad trip, like that can be a type of anxiety. If people are taking anticholinergic drugs like Benadryl and they get a paradoxical reaction, that can be a type of anxiety. Drug withdrawal can also lead to this as well. So it might not just be the presence of medications, but their absence can lead to this additionally. So whether it be ethanol, opioids, benzos, they can all lead to that as well. So treatment obviously is supportive if you can try. I find the best thing to try to help someone who has acute anxiety is tell them to just calm down, and they generally just fix it. I'm kidding. No one ever is calmed down by telling someone to just calm down. But supportive treatment is very important if you can try to talk them through their anxieties there. But from a pharmacologic standpoint, we will find that for acute anxiety, like acute panic attacks and things, benzos can be very useful here, which we'll get into. And then for more chronic management, you'll see that antidepressants are actually really good. So just like we talked about for depression, your SSRIs and stuff, they take weeks to kick in. So this would not be appropriate for sort of like an acute panic attack. You might need benzos in the short term in order to help kind of carry them over until their chronic meds sort of kick in. And so those are things you want to think about. So, you'll see a lot of that in this class where we're, seeing, okay, what works for the chronic period and what works for the acute case here. Because there's another case where you have to be able to sort of differentiate between those. BuSpar is another drug we'll talk about in just a little bit. It's a new one. And then rarely you can use some second-gen antipsychotics, but that is more of an off-label sort of use. We might see some more of that in the future as time goes on. So as I mentioned, antidepressants, your SSRIs in particular are, used for more acute, not really acute, like a panic attack is happening right now, but for more like long-term issues to prevent acute episodes of anxiety from happening. This is where your antidepressants come into play here. Mostly like your SSRIs are good here. SNRIs can be used as well. So things like, venlafaxine and duloxetine. TCAs I'd probably stay away from and use as a second line if they fail, sort of the more standard treatments there. And again, depression and anxiety are typically they're pretty common bedfellows there, so you'll see one come along with the other. So if they're getting treatment for their depression, then they may also at the same time be being treated for their anxiety, which is very helpful there, right? Again, why they work, we don't really know, but these patients will experience the same side effects, same everything as they would as treatment for depression. So again, that's, you can go back and review those slides if you need more info on that. Now, benzos, in terms of how they're working for anxiety, are the same way they work for seizures, right? So if you can imagine the neurons in the brain acting sort of having too much hyperexcitability, causing a seizure, well, a lesser degree of that would be a type of anxiety. You can imagine your neurons kind of firing off in a kind of disorganized, very hyperexcitable fashion. We can try to calm that down by hyperpolarizing those neurons, and that can help deal with that anxiety. So this is where GABA comes into play, and we'll see our benzos are going to be the primary thing here. Here's a more sort of complete list of benzos than what we saw for treatment of seizures. That one is usually a little bit more limited for seizure management, but here we have things like the ever popular alprazolam or Xanax. You may hear that on the street being referred to as Xanny bars. That's because the actual brand name Xanax comes in like a bar format. If you're familiar with Tetris, it looks like one of the long Tetris pieces. So that way you could like break it into, quarters if you needed to. But it's popular on the street from a, selling standpoint and whatnot. Other things like chlordiazepam epoxide, we have clobazam and clonazepam, which we've seen previously. Chlorazepate, diazepam, lorazepam, midazolam, oxazepam, temazepam, and triazolam. There are quite a few here, so if you can be able to recognize these as benzos, that is helpful. We'll talk about some of the differences here. You'll notice I have 4 of these that are starred. You should be able to recognize all of these as benzos, but the ones I starred here are what I call the lot benzos. Basically, when you have like elderly patients, you want to avoid benzos as much as possible because of the fact that one, they could have other medications that are interacting with the benzos. They may have impaired organ function to where they cannot clear the benzos very well. The ones I've starred here are ones that are typically more water soluble and they don't have active metabolites. So basically, they're easier for elderly patients to clear, and if you have to use one for an elderly patient, these are the ones you want to go with. Okay, so that's why I starred those. Those lorazepam, oxazepam, temazepam, and triazolam. The lot benzodiazepines are the ones that are preferred in elderly patients. As I mentioned, we can use them for all sorts of things, either for sedation, muscle relaxation, etc. So a lot of uses for benzos here. And we'll see that, as we mentioned, the differences between the drugs are usually going to be kinetic in nature. So, how fast their onset is may be due to the lipophilicity. Keep in mind, though, that patients, especially who have more adipose tissue, which you may see like in elderly patients, they can have buildup of levels of these drugs that are more lipophilic, which may lead to a longer duration of action, which may not be great, can cause, prolonged sedation for these patients here. So that's, again, why for elderly patients, we like more water-soluble, more short-acting meds in these cases here. Some of them will have IV versus PO. I'm not going to really focus so much on that for your purposes for testing, but certainly you may want to know things like, like drug interactions that are quite important here. So things like CYP interactions can be, I'm not going to go over all the specifics, but these drugs themselves don't inhibit any CYP enzymes, but other drugs can affect them. So if they're on something like rifampin or St. John's wort or something like that, it could definitely affect some of these benzos here and lead to the more prolonged effects or maybe lesser effects depending on the interaction. You'll see here things like lorazepam, clonazepam, and oxazepam are nice because they avoid any CYP interactions. Again, another reason why I like lorazepam in elderly patients more so than some of the other ones you'll run into. If they have liver dysfunction, they may not be able to clear it as well. And when they get metabolized, if they have active metabolites, that also extends their duration of action, which may not be good for elderly patients who cannot clear them. So again, that's why I focus on the lot ones for elderly patients. For everyone else, it probably is not going to be as much of an issue. Certainly, CNS depression is the biggest thing we're going to run into, from drowsiness to, typically don't see like respiratory depression, but you can see some pretty severe CNS depression where patients may appear to be, comatose as a result of that, but typically they'll still be breathing. You will find tolerance that can develop to this over time. and you can't see some memory impairment associated with this. Also, be really careful that patients are not combining this with other CNS depressants. Probably the most popular one is going to be ethanol. You want to avoid that because you can see a lot of synergy there, and can see potential for things like respiratory depression. I knew one student many years ago who said that, oh yeah, in college, it was always really economical to take a Xanax before going out to club at the bars, on the weekends, because then I only needed to buy one drink, and so they did it from an economic standpoint. And I said, boy, that's something. I probably wouldn't recommend combining those two together, but I suppose some people may not listen to advice given, but that's okay. So just be really cautious and tell patients not to mix and match these drugs here, because you will see some issues. But you'll find a lot of patients who are taking benzos plus opioids, and again, you can see the same sort of synergy there. The withdrawal thing is important too for patients who are taking these chronically. You can see things like agitation, sweating. The seizure is really the biggest thing we are concerned about. And how do you treat a seizure from benzo withdrawal? Well, you give them more benzos basically and just replace what they're missing. But you can see some rebound anxiety associated with that. So it's good to figure out, patients, who are using this for anxiety can get a lot of rebound anxiety from that, especially if they're worried about like where their source of their medication is coming from. That can be really challenging. And so it's not an uncommon scene at a pharmacy where someone maybe have run out of their benzos early and they're trying to come back and get a refill, and we tell them they can't get one because it's too soon. That is one type of anxious person you might run into for sure. You may find those people coming to you to get a new script or something, so that can be a challenge for sure. Withdrawal seizures can be fatal, so that is something you definitely want to be watchful for. Make sure patients know not to quit these cold turkey. Okay, opioid withdrawals not fatal. Benzo withdrawals, just like ethanol withdrawals, can be for sure. If you wanted to go a non-benzo route, we have something like Buspirone or BuSpar. This is basically a non-benzo anxiolytic. Doesn't have any anticonvulsant properties, no dependence issues, right? So this is not a controlled substance like you would see with the benzos. And so it also has less efficacy, so this is why it's more of a second-line agent that you'll see being used occasionally, and can take a few weeks to really kick in. Basically, we don't know why it works for anxiety so much, but it does have a partial agonist effect at one of these serotonin 1A receptors, which can have an inhibitory effect on serotonin. Again, it's probably not a real clear way of how it works. We just know that it does for more mild cases of chronic anxiety, I would say. Pretty light in terms of side effects as well, although it is metabolized by CYP3A4, so you just be watchful for those sort of interactions. Another thing we could use is a beta blocker in order to help deal with the symptoms of anxiety. And this is good for people who have sort of a performance that they need to do. So you typically think about this with like, things like musical performances, or if you have to give a public speaking engagement or something like that. This is good because we can utilize a beta blocker to block the physical symptoms of anxiety, as opposed to using a benzo, which may impair their ability to be able to give that speech or be able to play that music, whatever the case may be here. So if you need them to have a clear mind and not have any sort of sedation associated with the benzo, these are good to use. And so propranolol has probably been used the most commonly, but any of the beta blockers will be fine. And it sort of blocks things like the tremor that you see associated with anxiety, because you're blocking beta receptors on the skeletal muscle. You'll reduce the heart rate, you'll reduce the sweating, all of those things that you typically see as a result of nervousness, of anxiety. This can be ameliorated by that. And again, you can think about like how you want to use these if you were, say, to have anxiety before a test. Would you want to take a benzo right before a test where you're going to be passing out halfway through? I'll see that in the respondus monitor. I'll just see you kind of pass out. That would not be good. You probably want to take something that allows your mind to be clear and to think well, and then just block the physical manifestations. That way you're not having all the tremor and all of that. So that's how I kind of think about it. Make sure they take about an hour before the performance or whatever the case may be that they need it. And you don't want them to take it for the first time right before, because if they have like a really bad side effect or something, or they get really hypotensive and pass out, that would not be great to determine right before they need it. So if they can try to take like a test dose beforehand, that can be useful. Generally speaking, if they're having like an acute urgent issue, then you can utilize like a short-term benzo for like a couple weeks here, and then at the same time you can start up an SSRI or SNRI. If it's not an urgent issue, if it's just kind of a low-grade general anxiety people are experiencing, then you can just start SSRI right away there, no problem, no need for a benzo, as long as they're not having acute sort of like panic issues that they're dealing with there. And then if they're still not really responding, then you could try using something like a TCA, like imipramine or something like that would be fine to try there. So that's pretty much it for anxiety. All right. So I don't see any questions popping up, so I assume you guys are understanding this very well. That's good. Doesn't propranolol help with polygraph tests? LOL. I think that's been has been used in the past, and that kind of would make sense depending on what they're monitoring, things like your heart rate and whatnot. Here I would not say that I'm going to give any legal advice, but if you need to pass a polygraph test, I don't know if propranolol is going to be the thing to get you through that. So I don't know if I would recommend that, but again, your mileage may vary. So hopefully none of you are in a position where you need a polygraph test. But I don't want to judge anyone, so you never know. Anyway, so talking about ADHD, this is something obviously that patients, you typically think of children, although certainly you're seeing more and more adults nowadays that are being managed for ADHD, either kids that grew up with it or adults that are being recognized as having had it. They're being managed for it. It's really important to consider like what the goals are going to be here. So if a kid needs to be able to sit still for 20 minutes or do their homework, whatever the case may be, then that should be identified, so that way you can try to gauge whether or not your progress is actually, if your drugs are actually working or not. And certainly if you can avoid having to give medication for this, that is always going to be very beneficial. So looking at things like behavioral interventions, educational interventions, anything you can do to try to help out with this is going to be really, really important, because again, these meds are, they're pretty consequential. So you can keep a kid from needing to require amphetamine therapy. I would say that's probably a good thing overall. But if it's needed, it's needed. And so you have to kind of take the good with the bad there. So our stimulants we're going to be focusing on here are mainly going to come from the amphetamine category. So when you think about things like people taking a urine drug screen, and you think about them testing positive for amphetamines, you may be thinking about things like crystal meth and things like that. But these drugs are all of the same class, and so it's basically all the same thing. So people will show up positive for amphetamines on a urine drug screen because these drugs are the same thing basically. So these are going to be first-line therapy, and some of their mechanisms include things like, to a small degree, they block monoamine oxidase. This is not going to be a huge issue in terms of like tyramine reactions that you're going to see as you would with like something like phenylzine. But more primarily, you're going to see that they can block the reuptake of things like dopamine and norepinephrine. This is why these drugs can be addictive, is due to the fact that they're affecting dopamine. Some people do get a high from it, and that can affect that reward pathway. And they can also, to some degree, cause catecholamine release. They can kind of directly stimulate the brain to release some of those catecholamines there. You're going to find that failure to one of these does not preclude use of the other, so you can try around with different ones in the same category. So if someone fails dexmethylphenidate, for instance, you can try dextroamphetamine. That's totally fine. And typically, we use a lot of extended release formulations for these patients, because if, say, for instance, someone has to go to school for the day, you don't want them to have to carry that with them, or if you don't have to like store it with like the school nurse or something like that, that can be useful, because they can just take a dose in the morning and then they're fine for the rest of the school day. That's going to be ideal. So here are the ones you're going to run into, including methylphenidate. We have dexmethylphenidate. We have mixed amphetamine salts, which is a combo of amphetamine and dextroamphetamine. That's your Adderall. And then we have lisdexamphetamine, or Vyvanse. This is actually a prodrug. It gets converted over into dextroamphetamine when it passes through the liver after oral use. And again, all these are C2 medications, so this has the strongest regulations around them for drugs that are considered to have a medical purpose, right? So these are on the same level of control in terms of things like, Percocets and fentanyl, all that. These are in the same category. So you are limited in terms of like how much you can actually prescribe. For instance, you can't do any refills on these meds here. You can only do up to 90 days. So frequently what you'll find is a lot of these providers will write for 3 different scripts. And so that way they get a full 90 days worth. Each one will be a month at a time, but they'll have dates on them written that says do not fill this until the next month, and then the third script will say do not fill until the following month. That way the patient get the full 90 days worth, and the pharmacy doesn't have to dispense that whole amount all at once. So they just get a month's worth at a time. So in terms of adverse effects, again, these are going to have the same problems you would see with anyone taking an amphetamine or other stimulants like cocaine and things like that, obviously to hopefully a lesser extent because the dose is a lot less than you would see for like abuse purposes. But things like reduced appetite and weight loss, which may be okay for some patients, but for a developing child, probably not a good thing. Insomnia, certainly you can see that there for patients who are maybe taking it too late in the day, or if the drug is kind of lasting for too long for them. Tachycardia, hypertension, these are all things you'd expect to see with any sort of stimulant drug. Be very careful if patients have any history of psychotic episodes or hallucinations. This can be exacerbated by the amphetamines. And certainly there is a black box warning for their risk for abuse and dependence. And again, there's lots of really sad cases, especially for patients who, were taking amphetamines all throughout their childhood up through high school, and they graduate and say they don't end up going to college. And so their provider says, okay, well, you don't need the amphetamines anymore. Here, we're going to cut you off. And then they still have like that physical dependence to it. And so because they've been cut off, they end up resorting to other means in order to find amphetamines. And so there's been really sad cases of addiction like that. So it's certainly something to consider. Again, these are not meds to play around with, even though they're really effective at what they do. They can be challenging in the long term for some of these patients here. So as I mentioned, high abuse potential because they're really releasing all that dopamine, so that people feel good when they're taking them typically. And then there are the withdrawal effects. So typically these are the opposite of what you'd expect to see. So a lot of lethargy and low energy, and they're just kind of going right, so certainly not as severe as something like you would see with like a benzo withdrawal, where you'd see kind of excessive excitation. This is basically going to be a lot of like just lethargy and kind of fatigue and malaise and all that associated with that. There are some concern for things like growth stunting in kids. Maybe this is related to some of the appetite suppression. But basically, if you can give them some drug-free trials or some drug holidays throughout the year, that can be useful. So if you think about things like, spring break, or maybe not spring break, but more like summer break, if they're, off of school for a couple of months, then they probably don't need meds during that time if possible. So that can be useful there to give them a little bit of a break for that period. Now, if you had someone who did not want to use an amphetamine, and we do have a non-stimulant option, this is a non-controlled substance, so this may be good. They had like an adult patient with ADHD who didn't want to use an amphetamine in because they have a history of substance abuse issues. Some of adamoxetine can be really useful here. This is an SNRI. Again, how it got used for ADHD versus for depression, I don't really know, but it does basically the same thing as some like venlafaxine. But this is was approved. I think nowadays we're starting to see more amphetamine. Excuse me. Apologies about that. I think for adults, you're starting to see more amphetamine use because I think it's now being a little bit more recognized. But before that was more the case, and we saw a lot more adamoxetine being used for adult patients with ADHD. Keep in mind, it's going to have a lot slower onset than you would see with the amphetamine. So a couple of weeks, just like you would see for depression, versus 1 to 2 hours for something like Adderall. But again, the benefit here is no dependence issues. However, things you might want to look out for include things like they have a history of hypertension. This can be worsened by that. Suicidal ideation, just like we saw with the other SNRIs. All of that's going to be the same here. Madeline's asking, are stimulants teratogenic, or would they cause delayed growth in the fetus? I certainly would recommend not using them in pregnant patients, but specifically, I could imagine, maternal hypertension can be an issue with that. We can look it up, though, real quick if you guys want. Let's do Adderall. Switch over here. So you can see the black box warnings, including abuse potential. This one in particular has a cardiovascular issue, right? So you're worried about things like, hypertension, tachycardia, things like that. But let's go down to the pregnancy issues. So let's see here. Close out a little bit. Interesting. Data collection to monitor pregnancy outcomes following exposure. I don't know why it's not coming up. Give me more information. I guess I split them out into the specifics here. Okay, so although medicinal use of amphetamines appears to be low risk, abuse of the agent is associated with a significant toxicity for the embryo. Such use is contraindicated. Yeah, so it'd be one of those cases there where you're kind of looking at the risk versus benefits, and there's probably low benefits here compared to the potential risk to the fetus. So yeah, so I'd probably recommend avoiding that if possible. Anyway, you'll still find plenty of pregnant patients using amphetamines, though. That is an unfortunate thing you may see out there. For recreational purposes. Other things we can use, including non-stimulant options here, include things like alpha-2 agonists. And so we've seen these before when we talk about hypertension, but this includes things like guanfacine and clonidine. Basically, these are more sort of like depressants more so than a stimulant. And again, it sounds counterintuitive to use a stimulant for ADHD because you're like, well, this person can't concentrate anyway. But again, it helps them to kind of focus. That's more the big thing there. Is it helps them to sort of like bring their focus in so they can pay attention to something more purposefully than they would otherwise. Sometimes you'll find these patients may be kind of overstimulated, or in some cases you may need to kind of help deal with the side effects of the stimulants, which is not great to add on more medication, but you'll see this occasionally. But you can use this especially like at nighttime to help kind of calm the patients down and deal with that. So basically by preventing catecholamine release, it kind of deals with some of that sort of some of the hyperexcitability there. Probably not as effective as stimulants overall, but in terms of side effects, you can't see things like hypotension, constipation, and again, they could be more sedate for the first couple of weeks, but they should develop some tolerance against that. So basically, everyone's going to be treated a little bit differently depending on how they're kind of presenting, what their schedule is, comorbidities, things like that. Generally speaking, stimulants are used first line, and then if that's not going to be reasonable or effective, then non-stimulants can be used. In some cases, you may want to consider antidepressant therapy. Maybe they have an anxiety issue that's causing them to not be able to focus. Maybe an SSRI is going to be more effective than giving them something like a stimulant, which could worsen their anxiety. So just something to consider. Anyway, so that's it for that section. When I pull up the next one, do you all have any questions? All right, now we get into HIV and our STDs. Okay, so switching gears here a little bit, getting into no questions coming out, surprising. Getting into HIV, this is a big topic. I don't know if I'll be able to finish it today in the 30 minutes ish that I have here. Actually, I'll probably go to 9:50 since we got started late here. So if that's not feasible because you guys have something else to get to, let me know. But anyway, so HIV, what is this? This is a human immunodeficiency virus. It's a retrovirus, right? So it's basically using your own cells to produce more virus. It's able to use its DNA to encode onto your DNA basically, and you do the virus's job for it. You'll see two primary types of HIV, 1 and 2. Clinically, this is not going to be so important for us in terms of like medication therapy, except for one exception. But you may find in different geographic areas that one is more predominant than in another. I think HIV-1 is more predominant here in the U.S., but in other places you might find HIV-2 is more predominant. But and again, this is transmitted usually through sexual contact, but other ways are possible, including perinatal transmission. You could have parenteral transmission due to like things like IV drug abusers who are sharing needles, things like that. And the big problem itself is not the fact that the virus is hanging around, but it's what it does to your immune system. And basically, it destroys your immune system to the point where you become at risk for developing opportunistic infections and other things. And that's where AIDS comes from, right? It's the acquired immunodeficiency syndrome, where you're losing the CD4 receptor cells, so things like monocytes and T helper cells, and that can predispose you to all sorts of nasty diseases, things like PJP pneumonia, toxoplasmosis, things like that. And so, things that we may be exposed to, normal healthy patients are exposed to that have, they can fight off that infection no problem. These patients cannot, and so this is where they really get into problem here. And the mainstay of therapy for them is going to be pharmacotherapy, right? It's going to be highly active antiretroviral therapy or heart therapy. So if you were to look at the sort of life cycle for the virus itself, and I'm going to have that covered up, but if you look at the life cycle here, you can start to see targets for where the different medications can come into play. And so basically what you would see after, say, for instance, someone was using an infected needle or something like that, you would see the virus gets into the body basically, and there's going to be sort of a penetration point here where it actually gets into the cell itself and is able to uncoat. And then you'll see this is where it undergoes that reverse transcription, right? So we'll see that reverse transcriptase is a really important enzyme here for causing viral RNA to be encoded into DNA. And then that gets integrated into your cell eventually as you get down here into the down into the actual nucleus itself. So we're going to see RNA polymerase is another site for action of the drugs. And then now all of a sudden you're starting to produce the virus for it. And then it gets basically reassembled into a new protein or new virus and then can be sent off to affect another cell. Okay. You'll see all the different drugs that are here. This is, again, another case we're going to find there's a lot of different drugs that go into these categories here. And whereas before it's easy to tell if a drug is an antiviral, of ends in vir, you probably know it's an antiviral drug here. It won't be as clear because a lot of these will end in vir, and you need to be able to differentiate between different classes of these. And so I'll get into that and make it more clear as we go forward here. So anyway, so as I mentioned, understanding the life cycle helps us to understand how the drug therapy is going to be working here. And so again, the first place it's going to be getting in is by binding to that CD4 receptor. That's how the virus can tell which cell it wants to infect, is based on the presence of that CD4 receptor. And we can find that, if you can block that interaction, that can be useful. So we'll look at different things, different medications and be able to block that action here. There's also some co-receptors that can help out with this. So CCR5, which we'll talk about a little bit later on. Once it is bound, it will then fuse its membrane to your cell's membrane and then cause internalization of the virus. And then it'll have its RNA that uncoats and is kind of floating around in the cell. At that point, it uses that reverse transcriptase, as I mentioned, to make DNA. So again, that's why it's a retrovirus, because it uses a reverse transcriptase there. And this is really a big issue here because of the fact that it's a pretty sloppy virus when it comes down to transcribing its own DNA. And so that leads to a lot of mutations, and that leads to a lot of resistance to our drugs. So drug resistance is a big problem we're going to talk about here in just a little bit. But once it does that, it's going to be able to form a double-stranded DNA. And then, as I mentioned, multiple mutations leads to drug resistance over time. And it makes it more difficult for your body to fight off that virus, basically. It's hard to form antibodies because it's always shifting in terms of what the target looks like. Once it then gets down to the nucleus, it'll integrate via the enzyme DNA integrase. That'll be another target that we can look at. And then once that happens, the host cell now produces new viral proteins. And so then at that point, the proteins are produced. They're immature at that point. So there's a protease enzyme that comes along and causes it to be cleaved into more functional proteins. And then that forms a new virus and is be able to send out and can affect other cells, right? So again, it's a very cyclical sort of virus that you're going to see here. Anyway, so once someone is infected, it may take some time for them to even, see that they have an infection, because it can be silent for a period of time. But there's generally going to be an acute phase that happens here where they have a sort of acute retroviral syndrome where their body's sort of initially reacting to the virus itself. And then it kind of goes into a latent period. And these patients can be asymptomatic for years as their immune system kind of, over that time span is more and more diminished. And then they kind of get into more of a chronic phase when they're sort of recognized to have HIV. And then once they experience an AIDS-defining illness, either something like PCP pneumonia, Kaposi's sarcoma, lots of different ones that are out there, that's when they're determined to have AIDS, or if their CD4 count gets down to a sufficiently low level, that's when they're considered to have AIDS. So you can have HIV for a long time, and then once you get one of these conditions, then you're considered to have AIDS. And in terms of monitoring, we're going to see that CD4 cell count and the viral load are going to be really important. So these are the two big ones you're going to be monitoring, in addition to some other things, as we'll see here in a little bit. Obviously, our goals for these patients are to keep them alive for as long as we can, improve their quality of life. And again, if you ever have the option, there's a lot of really good documentaries that are out there about the HIV epidemic that started in the 80s in some of the big cities like New York and things like that. I recommend checking some of those out, especially there's one, I don't recall the name, but I think it was a Netflix documentary a couple of years ago. It's like how to stop a pandemic or something like that. Anyway, it's about the development of the first antiretroviral drugs and how it was pretty profound for these patients. And again, they were like really, really trying to get these meds because they were like, we'll take anything because we're dying out here. And they were just looking for any kind of treatment, but it was still in the experimental phase. And it was pretty wild to see how they were trying to help lobby in order to get these medications, through the clinical phase. They could start taking them, right? The clinical trial phase, so they could start having access to them. Anyway, but our goal for these patients are to get as maximal suppression of the viral replication. So ideally, you want to keep their viral load undetectable. That is the main goal there. And by doing that, it prevents them from the virus from attacking your cells. And so hopefully you're going to keep your CD4 count up. You want a high CD4 count, you want a very low to undetectable viral load. So, and this is something that changes pretty much year to year, and so I always recommend, and again, by the time you graduate, even then you may find that there are new treatment guidelines that are available. So I always encourage you to look up the most recent guidelines because this changes so frequently. But I'll kind of give you the basics here. So as I mentioned, we're trying to get as good a suppression as possible. We're going to do that with our HART therapy, which is the highly active antiretroviral therapy. And typically, we're going to require 3 or more agents in order to do this. And we're going to look at using complementary mechanisms in order to make that happen. And again, this is one of those things where you're going to find that as patients develop resistance, in some cases, they may not have a lot of options to switch to, as the case may be. So there's some challenges there. But the greatest thing is the fact that we have a lot better therapy nowadays than we had, say, for instance, like back in the late 80s and into the 90s. Because nowadays, HIV is something that is more of a chronic disease versus more of a terminal disease, as you'll see. These patients can live for a really long time because our antiretroviral therapy is actually really good nowadays. So if they're compliant, they can stay on this stuff for decades. And now they're dying of things like heart attacks and diabetes and all these things that come about with getting older and dealing with some of the metabolic complications of these drugs. So it's a good development, good problem to have that these patients are living for longer, because it basically was a death sentence back in the 80s when it was first kind of starting. We didn't have any therapy for it. So anyway, so there's a question for a long time of like when to start therapy, and this was a big issue, that kind of was a moving target in terms of what CD4 count you would start it at. Nowadays, we realize that you just start it. If someone has a diagnosis, you go ahead and start them on antiretroviral therapy immediately, regardless of their CD4 count, because one, that helps reduce transmission. If your viral load is undetectable, it's very difficult to transmit that over to someone else, and then you also have fewer AIDS-related events, so less instance of things like PJP pneumonia or toxoplasmosis, things like that. So these are the main classes of drugs you're going to see being used for HIV. So this includes some of our integrase inhibitors. We'll see our nucleoside or nucleotide reverse transcriptase inhibitors. So these will be our NRTIs. And then you have the non-nucleoside reverse transcriptase inhibitors, or NNRTIs. I know it sounds confusing, but we'll look at the differences there between the two. We'll then have our protease inhibitors, and then our entry or our fusion inhibitors, and then a co-receptor inhibitor. So we'll see there's lots of different categories here. We're going to look at how we're going to be combining these together in order to get a full regimen. Because again, it's usually going to be 3 or more medications that patients have to take. And again, back in the day, it used to be like they were taking dozens of pills every single day just in order to get their regimen in. Nowadays, some patients can just take 1 pill a day. So it's pretty awesome that we've been able to come this far in a relatively short time frame, if you think about it. Starting in the 80s, and so we're getting close to 40 some odd years, which is depressing for me since I was also made in the 80s, but regardless. Anyway, let's get into our nucleoside or nucleotide reverse transcriptase inhibitors. These are basically based off of normal purine and pyrimidine nucleotides. And so you can see they are analogs of things like thymidine and guanosine and adenosine and all of that. I don't really care necessarily, that which nucleotide that these are falling under necessarily, but you should be able to recognize these as NRTIs. You should be able to see, okay, if I see imtracitidine, I know that's going to be an NNRTI. Okay, that's important for developing a regimen for these patients here. I also put all of the abbreviations for these drugs. This is another case. You'll find two areas of medicine where they love their drug abbreviations, and that's oncology and that's infectious disease or management of HIV. Some of these are related to their like actual chemical names, and are not related to their generic names. You don't need to know these. I just list them here just for information purposes. So if you ever hear someone like an HIV practitioner talk about 3TC, that's lamivudine. And again, it's like if you look at the two there, they don't seem to make any sense in your mind. And that's why you can see medical errors too, right? Because you can see issues of maybe people are not on the same wavelength in terms of abbreviations, and that can lead to errors of transcribing or medication orders, for instance. So always be careful when dealing with abbreviations. But the ones we have in this category here include stavudine, zidovudine, then we have imtracitidine, lamivudine, abacavir, didanosine, and then tenofovir. These are going to be the backbones to a lot of heart therapy. So these are good ones to know because these will come up over and over again, as we'll see here in just a little bit. So again, how are they working basically? Well, what you would normally see if you have, say, the enzyme reverse transcriptase here that are taking the viral RNA, so it's reading along each of the nucleotides, and then producing the new DNA that gets eventually integrated into the host DNA itself. This basically is going to put a stop to that. It acts as basically a false nucleotide. It gets incorporated into that new DNA, but then you can't add anything onto it. Basically, it is lacking the components needed to elongate that DNA. So if you can't do that anymore, then it doesn't matter if you have that viral RNA there because you can't replicate the DNA unless you cannot infect that cell. So this is why this is useful here in order to prevent viral replication. So again, most of the time you're dealing with these drugs here, it's either you're changing drugs because of resistance issues, or more often than not, it's due to side effect issues. So again, finding something that's going to be most effective for a patient, given given the side effects they're experiencing, is going to be really important here. Some of the newer agents are nice because they lack some of these side effects. So for instance, things like stavudine, didanosine, zidovudine, really early drugs we had on, they had a lot of horrible side effects. I remember we had a guest speaker one time in pharmacy school who had HIV, and they'd had it for decades. And basically they were talking about being on, I believe it was didanosine they were on, and just the horrible diarrhea that they would experience. They'd have to bring extra clothes with them everywhere they went because they never knew when they were going to have an accident because of the medication. But it was either that or die from an age-related disease. And so he took the diarrhea, right? So nowadays things like abacavir, tenofovir, they tend to have a lot better side effect profile, which is beneficial. Some of the things you can run into are going to be things like neuropathies you can develop in here. Here you can have things like lactic acidosis with a fatty liver that can develop. These are things you monitor for. So obviously LFTs. If they're complaining of belly pain, look at things like lipase because it could be related to pancreatitis. Things like that you want to be looking for. Also notable here with abacavir specifically is you actually have to do pharmacogenetic testing on this one before you initiate it. So you're looking specifically for this HLA B5701. Again, just know that abacavir you have to do hypersensitivity testing for. I don't care that you know that specific mutation, but you have to test for the mutation. Otherwise, if they do have this and you give it to the patient, they can actually end up developing anaphylaxis. So if you need to start abacavir, you'd want to do that testing beforehand, make sure that mutation's not there, and then you're good to go. If they do have it, then abacavir is going to be contraindicated. Okay, next we have our NNRTIs, or the non-nucleoside reverse transcriptase inhibitors. So these basically affect the enzyme itself. So basically it kind of plugs it up and prevents the viral RNA from being read in the first place. So this is why you could see an NNRTI being complementary to an NNRTI, because they're working on blocking that transcription via two different mechanisms. One's affecting the enzyme itself, the non-nucleoside reverse transcriptase inhibitor, and then using an NRTI with a nucleoside reverse transcriptase inhibitor. You can see how that's complementary, and so you'll see these two being used, two classes being used together pretty commonly. So with our NNRTIs, a relatively small category here, we have dolaverdine, efavirenz, we have nevirapine, etravirine, and then rilpivirine. These ones here you're going to find in terms of side effects, just monitor for liver function is the biggest thing. They can also have some rash that can develop with this. And then interestingly, resistance is a big problem with this category of drugs here. So this class is sort of going out of vogue in some respects because once you develop resistance to one of these, so if a patient was on like stavudine for a while and they developed resistance to that, it confers resistance to like almost the whole category. So once you have that, then you can't really use anything else in this category here, which is a problem. The one that was an exception to etravirine, you still may have some activity. We'll talk about resistance testing here in just a little bit. Up next, we have our protease inhibitors. This is probably the most the biggest category here. But again, be able to recognize which ones are protease inhibitors versus an NNRTI, because you want to make sure that you have a good feel for how to make these regimens in just a little bit, which I'll get into more details on. But in this category, we have atazanavir, darunavir, we have fosamprenavir, we have indinavir, lopinavir, nelfinavir, ritonavir, sequinavir, and then tipranavir. Again, don't just go off the vir on the last name. You just know it works for viruses, but it may not clue you into specifically which category it fits into within HIV management itself. But how these work is that once a cell has incorporated the viral DNA into it, now that you're producing viral proteins, it comes in sort of this uncut, sort of immature form, and protease will come in and then chop it up into more of the active proteins, and that can then coat itself up, send off and infect another cell. You inhibit the protease enzyme, you prevent that cutting from occurring, and then it's just an immature protein floating around, not doing anything, and that prevents the replication of the virus. So that's how that's working there. Adverse effects wise, you're going to see a lot of GI distress related to these. You'll also find a lot of the metabolic effects are an issue here. So patients are on these for a really long time. Include you can have hyperlipidemia, glucose intolerance. Again, good problems to have because the patient's alive, but something you may have to manage, especially if they have any of these issues beforehand or they develop them just in the normal course of life. Interestingly enough, you can also have this lipodystrophy that occurs here, and so they call this the buffalo hump. So if you ever have a patient that has developed that, it could be related to long-term use of protease inhibitors, which is kind of interesting, sort of unique side effect of this class here. In terms of kinetics, most of these, again, are going to be metabolized through the liver. And so one of the things that's actually interesting here is we can utilize pharmacokinetic interactions for our own benefit. So this is a case here where we can try to boost levels of our protease drugs by utilizing them with a CYP3A4 inhibitor. A lot of the drugs go through CYP3A4 in terms of metabolism. If you can block that, you can boost levels of those drugs and get better antiretroviral effect. And so this is either done with ritonavir, which itself is a protease inhibitor, or cobicostat, which is another CYP3A4 inhibitor there. And so this leads to higher drug levels, which means better viral suppression. Sounds like a good thing. And so you have to dose your drugs less frequently. However, you do want to look out for interactions. I don't even know what that means, but interactions that can happen here. So again, if they're on something like simvastatin because they develop hyperlipidemia due to being on lopinavir or something, you do have to worry about those interactions there. So that's something you definitely want to watch out for. Maybe switch them to something that would be not interacting potentially. And so you can, I'm trying to see if I include here. So like for instance, if you're here, look at lopinavir, this one actually comes in a combination with ritonavir already, so it's already boosted. That is the drug Kaletra. It's a brand name for that combo that you'll see there. But very common that's going to be the fourth drug of the regimen is ritonavir or cobicostat added on to boost levels of those other drugs. So definitely look up those interactions for patients who are taking, again, you may not be the provider who is ordering the HIV meds, but you have someone comes into your ER, your urgent care or something who are on those meds and you want to order something else to give them. Look at those interactions because you never know what could be problematic there for the patients. Next up, we have our fusion inhibitors. This includes the drug enfuvirtide, or Fusion. This is basically prevents the envelope infusion, prevents the actual virus from basically fusing with your cell to get in. And if you prevent that, keep it from getting in your house in the first place, and it can't ever infect the cell. Interestingly enough, this one is specific for HIV-1, and so that's why you can see, like here in the U.S., you're probably seeing more use of this drug versus some places. I think like in certain areas of Africa, I believe HIV-2 is much more predominant. You find a lot less use of this drug because the patient has HIV-2, or if they have HIV-2, this drug does not work for them. So it's kind of interesting from that standpoint. This one is a peptide-based drug, so you do have to worry about things like, anaphylaxis associated with that. Because it's a peptide, it has to be injected, so no oral administration is going to be okay for that. And so it's given as a sub-Q injection. You do see a lot of injection site reactions. You can see things like erythema, nodules that can form there, so it's good to make sure they're rotating around the site and not injecting into the same site every single time. Actually, we have the CCR5 antagonist is another single drug category as well. This is Maraviroc or Cellzentry. This one does work on both HIV 1 and 2. All the other categories we've seen as well work both for HIV 1 and 2. And basically, this blocks the human receptor. It actually doesn't block the virus itself, but it blocks the human receptor. And this is really going to be dependent on the type of virus, because a lot of times HIV will be looking both for the CD4 receptor. They also look for the CCR5 receptor as well in order to cause the fusion and entry into the cell. So if you have a patient who if you have a virus that is not looking for that CCR5, then this drug is not going to be working all that well. And so that's a mutation that can develop where basically the virus can basically lose that need to look for the CCR5 and can go into the cell without it. So at that point, this drug would be ineffective. So that's something you'd have to test for beforehand. Again, pretty well tolerated, but certainly look at their liver function. That's probably going to be the biggest thing you're monitoring for with a lot of these drugs talked about in HIV is just the liver function. And then we have our last class here, I believe, is the integrase inhibitors. This is the newer class, but is really being pushed as like kind of gold standard for a lot of like initial regimens. And so this includes things like raltegravir, dolutegravir, elvitegravir, and then bictegravir. And again, these are cases where you can actually see them combined with like a CYP3A4 inhibitor like obicastat. So like that way you get the boosted effect there. But basically, these prevent the viral DNA from being incorporated with our DNA. So it prevents that integration from actually happening by blocking the integrase enzyme. Kind of makes sense. Think about it that way. And again, very well tolerated, which is why we see a lot of these being used as sort of the for a lot of initial regimens for patients that have new onset HIV. You'll see a lot of this being used. And so, for instance, you can get like one pill regimen sometimes with this. So like bictegravir, if you have like emtricitabine, tenofovir, and that's just like one pill regimen. You're good for maybe years potentially if you're going to be compliant with it. So as I mentioned, in terms of like drug interactions, some of these are going to be on purpose. So for instance, using ritonavir, but most of the interactions are going to come about through CYP3A4, and some of these may actually induce CYP3A4. So some of your NNRTIs can actually do this, but most of the protease inhibitors will inhibit CYP3A4. So again, it's something you just have to look up whenever you're combining drugs. And this is really important too, because think about some of the opportunistic infections that they can get as a result of being on these or having HIV. That can include things like tuberculosis, right? They can't really fight off that infection, so they get TB. And some of the drugs can have major interactions. So for instance, rifampin, which is used to treat TB, is a major CYP3A4 inducer, and that may lower levels of some of your other HIV meds, and that causes viral suppression to be inhibited, and then the virus can just grow and do its thing, leading the patient to have worsened immunosuppression, leading to other infections. So you can see how it's kind of a bit of a cycle there that you want to try and interrupt as best you can. Also, look up things like food-drug interactions. Some of them require more acidic environments to be absorbed. So just when in doubt, make sure you're looking this stuff up. People that work with HIV every single day, they know this stuff like the back of their hand. I took a whole elective in school just for HIV. It was a whole 6-week elective where this is just the stuff we went over. So there's a lot to it. Again, this is more of a survey of the topic as opposed to the full story here. As I mentioned, though, this is an evolving process, and so new recommendations are always being made. So if you want to look up the current guidelines, you can always go to aidsinfo.nih.gov. So this is a government website where they always post up-to-date information about management for HIV and AIDS. A very handy resource if you're dealing with these patients. But what do you need to know? Basically, the regimens that are going to be put on should be at least a minimum of 3 drugs, with 2 of those being an NRTI, right? So that means tenofovir and lamivudine, for instance, right? Then that will be in combination with something else, either protease inhibitor, NNRTI, or an integrase inhibitor, most commonly. especially on newer recommendation talk about just using dolutegravir and lamivudine, which is kind of interesting. That's only a 2-drug regimen, but more commonly you'll probably see a 3-drug regimen. So as an example, you could do something like an integrase inhibitor plus 2 NRTI, so bictegravir plus tenofovir plus emtricitabine. You could do a protease inhibitor plus 2 NRTIs, so darunavir, which may be boosted by ritonavir, so it's now a 4-drug regimen. Or you could do an NNRTI plus 2 NRTIs. This is less preferred nowadays just due to resistance issues, but it could be used for some patients there. So most people will likely be started off on an integrase inhibitor, mainly due to the favorable side effect profile of integrase inhibitors as opposed to protease inhibitors. So that's probably going to be what's seen most commonly. But I can already guarantee you, I'm going to have a question on the test. It's going to say which of these regimens is appropriate for a patient with new onset HIV. And I'll have one that probably has like 3 protease inhibitors on it. You say, well, that's not right because you don't use 3 protease inhibitors. I may have one that has just NRTIs. I may have an answer choice that has 2 integrase inhibitors and an NNRTI, right? So you have to be able to recognize what the proper regimens are based off of being able to recognize the drug names and fitting them into their categories, okay? So that is something I'm already guaranteed there'll at least be one question about just that. Look how nice I am. I'm telling you the test questions beforehand. Boy. So adherence is a huge thing with these patients, especially considering like, they may have, issues in terms of like, they don't know where they're going to be living at because they don't have a home, right? Maybe they're IV drug abusers, and so they have addiction issues they have to worry about. So adherence can be pretty complicated, making sure they're going to be sticking with it. But this is a huge problem because if they're not going to be adherent to their regimens, then the resistance will develop, right? That's just kind of a known thing, especially if they're only going to be like really sporadic. Just having a little bit of expression or a little bit of exposure to those drugs leads to that resistance. And so it really needs to be all or none sort of phenomenon. Like they need to be on the drug regimen, be adherent to it. Otherwise, they're going to get resistant. And then you lose that drug. They can't ever be on that drug again because now it's resistant, right? Again, a lot of issues. It could be due to psychiatric illness, could be adverse effects that the patients just hate, could be unstable social circumstances, all kinds of things can lead to this. This is why, again, good patient education on why it is important to take these meds, how this is going to extend their life and keep them around for longer. That's important to let them know. If possible, always use combination drugs. So again, we're seeing nowadays more and more like triple combo drugs, like that bictegravir plus emtricitabine and lamivudine, I believe, or emtricitabine tenofovir, I believe what it was. That combo is just one pill you take one time a day. It's awesome. That was not the case many years ago. But you can be aware of things like food restrictions and things like that. They need to eat it with more acidic food, more fatty food, whatever the case may be. Here's just some examples of the triple drug regimens you can run into. This one's actually a 4-drug regimen, so you can see elvitegravir, so that's an integrase inhibitor, plus cobicostat, and then emtricitabine and tenofovir. So it's just, again, one pill a day, which is really beneficial to these patients here. So that gets into resistance testing. There's 2 types of resistance testing you're going to run into. There's phenotypic testing and genotypic testing. Genotyping, the virus itself is easier to do, it's quicker to do. And this basically just tells you what's the DNA sequence for that virus. And so based off of that sequence, you can identify certain mutations that confer resistance. So if you see a certain sequence there, you can say, okay, well, I know this virus is going to be resistant to X drug, right? This is useful in the short term because it's quick to get back as opposed to phenotypic testing. But may not be as informative because you can find some really complex interplay between different mutations to where just looking at the sequence may not give you the full story unless you actually saw what the virus is doing in vivo, right, in the real patient. So that's where phenotypic testing comes from, and this is more so like what you would see with like a culture and sensitivity of a virus or for a bacteria. So with a culture and sensitivity for a bacteria, you culture it out onto an agar plate, you let it grow, and then you expose it to different antibiotics to see what kills it, what doesn't. That's very informative because that tells us whether something is resistant to penicillin, for instance. You do the same thing here for phenotypic testing for the virus, which basically will expose it to different concentrations of the drugs to figure out, basically in vivo, what is that virus responding to or what is it more resistant to. This is slower, Costs more, but can be very valuable because especially for patients that have really complex mutation patterns, really resistant kind of virus, it can be useful there. So genotypic testing, easier to do, not as much information as the phenotypic. So let's talk about a couple of special circumstances for these patients here. For instance, how about pregnancy? Like, what do we do for these patients here? You're going to basically find that by suppressing the virus as much as possible in pregnant patients, that helps to limit exposure to the fetus. Okay. One thing you do want to avoid is efavirenz because it can cause, some people call efavirenz, but due to neural tube defects, issues. So that one you definitely want to avoid there. And then one thing we'll do once the fetus has been born, we'll actually give them about 4 to 6 weeks or so of zidovudine, and that way it tries to suppress any virus that baby did pick up, suppresses that to make sure that they don't have any replication there. So just a single drug regimen for them, about 4 to 6 weeks. And again, all of that is going to be dependent on how maximally suppressed the mom was during pregnancy. During that time, you probably want to avoid breastfeeding if possible because you could have some breast milk transmission of the virus, so that's going to be avoided for those patients there. There's also chemoprophylaxis, which may happen in cases for patients who are at high risk for catching the disease in the first place. So, for instance, if you are working, say, in the ER and you're suturing somebody that has HIV and you accidentally stick yourself with a needle, right? That's a possible risk for transmission. And so you may need to go on chemoprophylaxis for a period of time. And so this is ideally, you'd like to know the HIV status of the patient, right? So if you had that needle stick, it'd be nice to know, but it may not always be the case. Maybe the patient's gone, and then the needle stick happened, lots of different things. So if it's not possible, you always go to the worst case scenario and just assume they have it until proven otherwise. And so we want to start within as early time period as possible. This is where typically like your employee health department will come into play here, and they will have medications available typically, or be able to get you a prescription to get this filled as soon as possible within a couple hours. And then typically the recommended regimens, tenofovir, emtricitabine, and then raltegravir, so integrase inhibitor plus 2 NNRTIs. You do that for 4 weeks. So if you did pick up any virus, it is being inhibited as much as possible to prevent it. Hopefully it'll just die out and not cause infection in the patient. Of course, you'd go back and be tested there. In some cases, you may actually do pre-exposure prophylaxis. And so this would be something to where if you have patients who are at high risk for developing the disease due to maybe, for instance, they are a known IV drug abuser, or if you have a couple who are serodiscordant, so one patient has HIV, the other doesn't, they don't want to transmit it between each other. Excuse me. So basically, one, you have to prove the patient's seronegative prior to initiation, and then you could start off with a more limited regimen like tenofovir and emtricitabine. So that way, in case they do have any exposure to it, they can go ahead and prevent that from replicating. So you may see that as a pre-exposure prophylaxis in some rare cases, but that may be useful for some patients there. And then basically what we're looking for is to make sure that their CD4 count stays high and their HIV RNA load is undetectable. That's the main goal, is you don't want to be able to even measure it. And so basically, they do resistance testing up front to see kind of what the virus is likely to be susceptible to. And then you'll monitor the CD4 count and the viral load every 3 months until that RNA is undetectable. And at that point, they can just continue on that regimen. They'll come back regularly to see if they have any, making sure they're still being adherent and preventing the virus from replicating. And really the big reasons why you might change regimens would be if, one, they can't tolerate it due to side effects, or if they have a treatment failure. So you come back, say in 3 months, and the virus is still able to replicate, still measure all the RNA, or if they have documented resistance. So maybe start them off on tenofovir, and comes back resistant, you switch them over to something else. I think my respiratory tract is trying to tell me to stop talking. And this is a good stopping point, so I'm going to do that there. Anyway, do you guys have any questions before I let you all go? As you get so teary-eyed talking about this stuff. Just kidding. I'm getting sick. Any questions? If not, I'll go ahead and look at the quiz, see if there's any high misses, see if there's any issues there. Otherwise, I think I looked okay grade-wise. But if you have any questions, feel free to email me, and we can talk about it there. And I'll get your prescriptions graded this weekend. And I'll get the next assignment posted up so you can start to work on that if you like. probably gonna go hack up a lung right after this. So, um, yeah, I don't see any questions up on the board. So yeah, you guys have a great weekend. And I will see you all next time. Yeah, happy spring break to you as well.